Hello everyone. Thanks for coming tonight. I'm Katie McKinnon. I am a paediatric trainee from London, and we'll be talking tonight about the clinical MRCPCH exam in its current sort of semi-face-to-face format. Aya, a trainee who has recently sat the exam, will be joining us a little bit later to talk to us about her experience as well. There's not going to be anything sort of dramatic in tonight, but hopefully it will be a useful session to go through some of the practicalities of the exam and some tips for revising and for the exam itself. I have no specific reason to be talking to you except that I sat the exam twice when it was in its normal face-to-face version. I was a little bit involved in the RCPCH when it was becoming virtual, including sitting it as a tester for the virtual type of thing, and I have done various teaching for it, and so have spent more time than I probably need to reading the RCPCH website and contacting them about specifics. So I know a bit, but do jump in if you think I'm saying something ridiculous or you have any questions. This session will be recorded and I'll put it on the London School of Paediatrics YouTube within a day or two, and that's enough admin. Wonderful. So the aim of the MRCPCH clinical exam is to assess you to check that you are the standard of a newly appointed ST4. So in the current version of paediatric training that you are about to start as a sort of general registrar, it will be assessing you on all of the things that you do all day, every day. And so you don't need to overthink a lot of it, because it is the communication, history taking, making management plans, examining children, although in this face-to-face no children version it's a little bit different, thinking about child development, thinking about professional behaviour and ethical practice, all of the things that you do every day. And just to note that it is supposed to be testing you on what you have learned through your training, and so it is worth having a read of the curriculum because it is designed to be matching up against that. And so just so you have that awareness in the back of what the college thinks you are being taught and so what they are going to test you on. In terms of the current setting, so for the October exam, it will be a face-to-face exam, but with no patients. They had said that they were going to try and get patients back for this sitting, so maybe for the next one there will be. If you've sat the exam in a different version or started revising for a different version, it is the same. The children are the same, and lots of the stations are very similar, if not identical. The difference being that you have to describe your examinations, and there will be role players rather than children for the development, the history, and the communication stations. And there's no extended clinical station, which there had been in the virtual version. So personally, I find it best to sort of think about it like a simulation, which all of you have done hundreds of. So you have to just talk about what you think you would be seeing and then deal with it in that situation. They would still be reasonable adjustments and things are possible. You have to just tell them in advance. And there's cues, which I will talk about a little bit more later, that you will have had if you ever sat it or revised in the virtual only format. So this is the website that if you haven't looked at it, you should definitely look at it. There will be, I'll stick the link in the chat in a little bit, but it's the RCPCH page where they have all of the information about any current changes or structures. There's some really useful documents which I'll highlight later. It also includes some videos of mock development and clinical stations, virtual, but with a scenario rather than a child, so useful to see that sort of talking through of your examination. In terms of the timing, so it's 160 minutes and it is exhausting, but goes really quickly. Once it starts, you just keep going till the end. There's 9-minute stations, which are the clinical stations, the communication stations, and the video stations, and then the longer stations, which is development and history taking. And you get a knock 3 minutes before the end of each station, which will then guide you to your wrapping up chat. And you get 4 minutes between each station, which is a bit longer than it used to be, and allows time for your reading and preparation for some of the stations. Good. Oh, that's come out a bit weird. This is the map of the exam rotation. It's copied from the RCPCH website, but has come out strangely. But basically, you go from each to each one. There are 2 versions of the development station because you then go into one of them at the same time as someone else, and the same with the history taking, and you just go through. At the beginning, when you arrive, you get a list of your specific order of the stations so that you can't get lost and someone is telling you where to go. There's usually 1 examiner per station, so the candidate is assessed by a different examiner at each station. There's sometimes an extra examiner that sort of pops in and out, but rotates. They are examining the examiners, not you, just so that it doesn't stress you out. In terms of the differences between the original face-to-face and the face-to-face no patients, there are very few differences. The pass mark is slightly different. So the pass mark is 78%, 64 of 82, which was set using the modified Angoff standard setting process. And of course, the main thing being that there is a difference in the where role players are used. In terms of the marking, there are 5 domains, and they're split between the different stations, marking either as below standard, borderline, or meets standard. Plus, there's the domain of professional conduct, but you'd have to be pretty bad for that to be counted, and it's usually isn't a sort of immediate fail. It would just be discussed within the marking system at the end. When you're marked as borderline or below standard, the examiner then marks more information on feedback boxes at the back of the marking sheet, which is much more detailed than it used to be. So is hopefully, if the worst happens, should give you some feedback on terms of what to do differently next time. But I'll come back to that. So each station is not marked separately anymore. So you don't fail a station. You are marked on these different domains throughout the different stations. So these are the core skills demonstrated across the stations. And it's a judgment about your performance across these domains that is then how you pass. And it's trying to standardise it so that there's not one awful station in one location where everyone fails it and different elsewhere. So it's more equitable. And it is supposed to make the feedback that you get more useful as well. And again, these are pretty broad areas, but it's things that you are used to doing and can practice doing over the next few weeks. For people that like planning, so there's some that aren't involved in most of them. So information gathering, you only need to think about in the development and history taking, imagine. Let me just mute you. Good. And then there's others that are used in more stations, but we'll go through the different stations. So these are the anchor statements. So they are the statements for the domains, and then these domains are then included for the different stations. So for the information gathering, it's about what questions you're asking and how you're doing it, explaining your clinical accurate information, and making sure that you understand them. All of these documents are on the RCPCH website. I've just pulled them together for ease because there's a lot on there. Physical examination, so a structured, systematic examination, making sure that the patient is happy or the role player is happy if required, and using equipment appropriately. Signs, saying the signs that are there and not the signs that aren't there, proposing your diagnoses and the implications, and then the management plans, as you might imagine. And then there's the communication skills, and which are communicating and then listening. So again, developing a rapport, saying who you are and what you're going to talk about, using appropriate language, and then discussing the management plan and making sure you've covered the ideas, concerns and expectations of your role player patient. So the describing the examinations is the thing that is least like your normal daily practice. So this is the thing that you need to practice in the next few weeks. So you have to describe what you are examining in a structured, systematic way, and be fairly precise about it. So I would look at muscle bulk and compare both sides, looking to see if there is any wasting, rather than just I'd look at the muscles, to sort of try and get across what it is you're looking for. And then there's different types of cues that are included in this. So there's dependent cues and universal cues. Dependent cues are the ones that you only get if you say what you're looking for. So you say, I would test the lower limb reflexes with a tendon hammer, and then the examiner says back, the reflexes are brisk on the left. So they will interrupt you with the results. So try, when you're practicing, to take breaths and pauses in between your flurry of the neuro exam. Make to let them interrupt you, so that it doesn't throw you off. Just give them that time for them to feed back. The universal cues are, if anything, the silver lining of the no patient approach, because they're given at the start of the session. So they're things that you would see in the room when you went in. So an obvious scar, a wheelchair, those sorts of things. And so they are photographs, audio or video recordings, and you are given those before you start the station. So in those minutes beforehand, you are usually given those as part of your preparation. And so that you can already start your planning as to where you're going based on that. So you will always get the universal cues, as the name suggests. The dependent cues, you have to have said the right trigger for them to say. From speaking to people, like if you didn't say enough, like if you just said, I would test the reflexes, then they might encourage you a bit to say, I would test the lower limb reflexes, the knee, the blah, 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 and then they would give you something more specific. So it wouldn't necessarily be that they just wouldn't give you anything, but it might just take a bit longer. So if you're ready, that's the speediest route. So I'm just going to talk through the different stations and go through some of the specifics. So the clinical station is the short clinical station, as it was briefly previously. So you are undertaking a structured and systematic clinical examination and identifying the clinical features. As always, at the standard of a newly appointed ST4, you are not supposed to be some magnificent professor of cardiology. You are supposed to be safe. That is what they want. There are 4 of these, and there's 9 minutes for each station with a 3-minute warning before the end, plus the preparation time in between. There's 3 minutes warning, so this is when you do your presentation and your discussion. So for this, the anchor statements are, so I've obviously picked the meet standards selection. So this is, it's physical examination, identification of clinical signs, your clinical reasoning, and then management planning are the domains that you are looking at in this station. So it can be anything, any system or case. The examiner starts with an instruction like, this child has a heart murmur, what do you think is the cause? Or, this child has difficulty walking, please examine her lower limbs and see if you can suggest a diagnosis. and then the candidates go through their do their station, and they then present their findings and their differentials. Sorry, I should have taken that out. It was previously that you didn't provide a management plan, but since they've gone back to face-to-face, it is including a management plan as well. And this is the list of areas that could be covered, which is basically all of paediatrics. So you can't narrow it down, but there are obviously things that are more likely to show up than others. But you could have, you know, a specific growth problem, for example. So what they expect is a structured, organised approach, which again might be easier to do in a no patient setting, where you're less negotiating with a child who might be becoming annoyed, and you just have to look and sound like you have done it before. And clinically you have done it before, but talking through it is a little bit different. So it's the rehearsal that is crucial. Competent at assessing all areas, obviously, identifying signs present and discussing findings. Again, some of that is a bit clearer because of how the examiners then have to describe those signs to you so that you can interpret them. Is a bit easier for you to find those signs, perhaps. You know, the silver linings to grab. And then discussing those findings and your interpretation, and then using your clinical skills and knowledge that you are ready to progress to level 2 training. Practice your presentation and have a structure for how you're going to do it. So different people like different things, but I liked sort of starting with your main findings, your main positives and your negatives. So if there is a heart problem, for example, then you would be saying no signs of heart failure, blah, 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 as a crucial negative. Then you list your differentials, and you can already start with your findings, thinking about what those questions might be in terms of your further investigations, management plan, etc. This document is on the RCPCH website and tells you what they want for their examination. So find it and read it. It's beautiful, and that it tells you for all of the main examinations, cardiology, respiratory, everything, what they want and how they want it. So read it. It's beautiful. That's all I have to say, really. It's very useful. And then, of course, practice is important. And I'll talk about it later, but I think practicing on real children is still important and useful, even if the exam hasn't got children in currently. The development station. So the aim of this is your ability to assess the areas of development and take a focused history about development, and including the impact on the child and family, importantly. So you're doing your information gathering, you're doing your developmental assessment using the equipment they provide, and then discussing the management plan. 23 minutes, 10 minutes of history, 2 minutes of summary, 8 minutes of examination, and then 3 minutes of management plan discussion. Children would have a developmental age of less than 5 years. That doesn't mean that they will be less than 5 years, technically. So you could have a 7-year-old who has a developmental age of lower, for example. And this, because it is a long station, covers a lot of domains. So there's the information gathering, physical examination and identification of signs, your reasoning and management planning, and of course the communication skills with the family. You gather your information with the history taking, and it will be about a specific for your then you will decide what developmental assessment to do based on that, and it will be a specific area of the child's development. So they won't say a full developmental assessment. They'll specify, or it will be clear from the history what area that you are then assessing. If it's before 2 years of age, they want you to estimate the child's development within 2 to 3 months. after that, they want within 4 to 6 months. There's a bit more flexibility. They may have a syndrome, or they may not have a syndrome. Your job isn't necessarily, unless it is Down syndrome or something incredibly obvious that you should be able to pick up clearly, you don't necessarily need to diagnose the syndrome or neurological abnormality. It is to assess the development and the bigger picture. And then your management plan is the broader sort of including the family and things. Again, the MRCPCH is very helpful in giving you a nice picture and list of the things that you will have access to so that it is standardised across the things. These are what you will be able to use in your developmental assessment. It's all the things you could possibly want. In terms of the history, it can still be pretty broad, so try and focus it down based on what they have told you and the domains that they're asking for. Often they will be wanting you to examine one domain and ask questions about the other domains to get that bigger picture. So the domains being gross motor, fine motor, speech and language, social and communication skills. But what you're thinking about is any etiology, past history that's relevant, family history, other delays or other medical problems and comorbidities, the impact on the family. So do they have social support? Do they have income support? You know, is there anything additional that they need? Education, so are they in a mainstream school? Do they have an educational plan? And who else is involved in their care in terms of the MDT? Who else needs to be involved in their care and isn't yet? This is the one that you probably won't have experienced very much unless you've had a community job in early on in your training. So this is the one that I definitely and others find hardest because you have done hundreds of cardiovascular examinations. You won't have done hundreds of these. So do practice it. They'll give you the universal cues in terms of wheelchairs, splints, those sorts of things. So bear that in mind. Start with the easy ones, easy tasks, and then move on to harder ones until you find the limit. And just being nice to families, comment, don't say they can't draw a square. Say today they weren't able to draw a square, because when you have real children, it is never the perfect situation, particularly in an exam setting. So you would want to see what they're like generally. This is a beautiful table that is available on the MRCPCH London School of Paediatrics website, which I'll give you a link for later as well. That is the developmental assessment station in one page, and with a few little annotations and things. This is basically all you need to know in terms of the gross motor, fine motor, speech and language and social, and the different things that you'll be assessing for that domain. It's beautiful. Written by Chris Kelly of Nearmate Designing fame. The history station is something you will be more familiar with. So you take a focus history, summarise, identify the issues and prioritise and formulate your management plan. It will either be a new problem or a specific problem in a child with established problems. So this is often potentially more common. So like a diabetic child with new weight loss, or a child with cerebral palsy who's got new feeding problems. You won't do an examination, but sometimes they give you things like growth charts or investigation results. And it's a 23-minute station. You have 14 minutes with the role player, which could either be like a teenager or a parent, and then you have a warning at 9 minutes through that, and then you have 9 minutes with the examiner with a warning 3 minutes before the end. The anchor statements for this one, again, it's a long station, so there are many. So information gathering, clinical reasoning, management planning, and then various different communication skills. In terms of what's to be expected. What is expected is being your usual lovely, friendly self and relating to the parent or child, even though they are a role player. You want a focused history, but enough to determine the problem, but it will be guided by what the issue is. Clear questions, no jargon, all the things that you would usually cover, but tailored to what you have. So it might be that immunisations are relevant. It might be that it's more about the treatments that they've used and what they've tried. Definitely explore the concerns, fears, expectations, because particularly with role players, but even with families, in the previous forms, they want you to pass. So if you are slightly missing the point and you say, is there anything you're particularly worried about, they will get you back on track and highlight anything that might have been missed, like that they have moved to a new school or whatever, and that's what's causing the problem. The respond to any questions. They might have questions, but it's not one of the things is not giving information, so don't give too much. What you're wanting is to gather. Summarize your history to check that you've understood and treat appropriately. When you get to the summary, don't summarise the whole history again. The examiner has just sat there and heard it. Some people use the problem list. Some people use SBAR, but just work out how you want to do it. Don't try and take a comprehensive history. The focus should be clear. If it's really not clear, you can always ask the examiner for a bit more advice, but they might. Sometimes some are more helpful than others, but it should be clear from the blurb. And as with the clinical exams, that you'll be already anticipating what's coming as you're thinking about your problem list or your SBAR. You will be thinking about what the next step is and what you'll be probably asked in a minute, and you can have that ready. The communication stations. So just briefly, I think Kate Reagan has arrived, who is going to take over from Aya as our trainee. I've got a few more slides to go, and then I'll get you to talk if that's okay. Thank you for joining us. So communication stations, the aim is to communicate appropriately, give factually correct information in an effective way in the emotional context. So there will be some non-clinical element to your communication. It will be a role player, but it could be anything. It could be a child, a parent, or it could be a health professional. I had a medical student as one of the communication stations in mine, for example. And it can include a telephone conversation. The examiner is not there to ask questions or interact with you at all. You only interact with the role player. And there's 2 of them, and they're both 9-minute stations with a 3 minutes before the end, as always at the standard of a newly appointed ST4. So the anchor statements are information sharing. So as you would imagine, you are giving information that you hope is accurate, but it is also about all of the other communication skills. So interacting appropriately, listening, and managing concerns, and creating a management plan with the role player. There's all sorts of types of scenarios. I'll show some useful things at the end, but the pink book of communication stations is great, and if you go through the whole of that, then you will have covered pretty much everything that could come up. So there's information giving, so really specific things like this person has been given this diagnosis, talk about it. If that is the case, it won't be something super rare. It'll be something that you will know about and can talk about. Breaking bad news, so things like an abnormal finding and what there might be. Consenting, so again, this would be for something that you know how to do in terms of the principles of legal consent. You would need to know how to do it to be able to consent for it. So things like lumbar puncture. Critical incidents, so things like wrong drugs and explaining them. And again, with all of these things, lots of them are things that you will have done in real life. It's just about making sure you tick all those boxes. Ethics, so refusing to have blood tests, or you know, extreme preterm babies with parents before delivery, those sorts of things. And education is a common one. So it's sort of like information giving, but in a more generally to a medical professional or a trainee, a colleague, and so you just tailor how you're doing it and teaching in a nicer way. So introduce yourself, structure, rapport and body language, picking up cues, and making it a conversation. So some of those marks are for your listening skills, so you do need to interact, not just talk, and use silence. So if particularly with things like breaking bad news, give them time for the role player to tell you what they need to tell you for you to get the marks. But as you would in real life, you wouldn't talk and talk, you would give them time and express empathy and sensitivity. Use no jargon, or if you have to use jargon, explain it. Diagrams are great and probably underused in real life and in exams. There's a likelihood that there may be non-patients, and so if it is, it would be a different type of communication, and it should be clear what it is that you're trying to do, and make sure you do it, and make sure that you check that they have understood whatever it is that you're saying to them. It is not a test of the sheer amount of information. So particularly if you get there and you are, for example, you are telling a patient about a disease that you know really well, try and focus down into what you actually need to tell them, rather than telling them everything you know about that disease. That isn't what is wanted. When you get the 3-minute warning, make sure that you start summarising and checking understanding. I was taught to say, can you explain that back to me so that I know I have explained it correctly, so that you're putting the emphasis on your explanation potentially being inadequate rather than them not understanding it or whatever. And thinking about if they have questions and making a plan. So signposting, next steps, making another appointment with them. If they need to speak to a senior, then say that you're going to arrange that. Do you have leaflets to give them, etc., etc. So pick the right information, try and give correct information. Explain it in an appropriate way, but in the emotional context, and manage the concerns. There will always be something specific that they want you to address, and the role players will tell you if you give them the chance. Video stations. So the aim is to look at clinical observations and decision making, and in the setting of the exam when there were patients, this was the part where it was clinical signs that couldn't be easily assessed in a live child. So things like acute signs, emergency department settings, where you're then thinking about your management plan. You've got 2 9-minute stations with 3 minutes to watch the video, which is only short, so you can watch it a couple of times if you need to, and there'll be a scenario to read with it, and then 6 minutes of questions. So this is looking at identification of clinical signs, clinical reasoning, and management planning. And these will be the more acute problems, so signs of respiratory distress, seizures, it could be things that could be elsewhere in the exam, so it could be things like murmurs or gaits, but it's more likely to be other things like rashes, meningococcal sepsis or something like that, which wouldn't necessarily be elsewhere. So just some general things before I get Kate to talk to you. So practice talking, that is the thing that is different from real life. The rest of it you know how to do. It's just the practicing talking. So have a group to practice with, find them, there will be someone else in your area, and stick with them and push each other. Be honest with each other. Don't say, oh, well done. No, say, you didn't say this, you have to say this bit in this order, blah, blah, blah. And that is how you get better. Push people to teach you. All of your seniors have gone through this and have pushed other people to teach them. So it's their turn. So have no shame. Try and use people you are scared of, because that is what it will be like. So if you can talk in front of the scariest consultant in your department, then you can talk in front of the examiner. It's not long left, but you're nearly there, but take some time as well. Don't go mad. Use your study leave. Different places have different rules, but mostly you are allowed to use study leave beforehand. I think you should see real children, but some people don't. But really, this exam is the most useful of the exams in terms of the rest of your paediatric training, and so it is a chance to go and see lots of things that you might not have seen before, if there are children with signs, and get your skills down, and talking through things is useful, as well as examining them. And think about those other things, so emergencies and temporary signs. Time yourself and stick to it. So you have a time, so when you go and see a patient or when you're practicing, don't let yourself ramble on. Don't do your examination and then go around the corner and do the questions. Do the examination and do the question straight away, so that you don't have some spare extra minutes to think about things that you wouldn't have in the real thing. Practice the presentation as well as the examination. It's the presenting that will prove that you've done everything and get you lots of the marks, and having your patter down is key. I use a lot of ers and ums, and just notice what you do. I use my hands a lot, as you might have noticed, and if I get anxious I use my hands even more, and so I when I was practicing presenting, I put my hands behind my back, and that helped me focus on what I was trying to say. Organising revision sessions can be great, and if your department is enthusiastic, then organising mock things so that you get that experience of doing the whole rotation is useful. Think about those small print exams. Have you looked at a Snellen chart ever? Do you know how to do an MSK or a thyroid exam? They do come up, so don't spend loads of time on them, but do think about them. Think about the communications and history. The pink book is lovely. I'll show it in a minute. Familiarise yourself with the equipment, the developmental assessment stuff, but also things like the ophthalmoscope, and think about what you would be using for what you're going to be doing. And they give you the mark sheets as well on the website, so look at them and use them when practicing, so that you're scoring each other and being strict. On the day, remember your ID and the admission document. They won't let you do the exam without it, and it's not worth the stress on the morning. It's smart casual, you can be sensible. You're being watched, but you are doing what you are doing every day. You can do it. You are, you are capable. You are doing this job. You can take notes, so you can take notes as you go, like in those 4 minutes of preparation in between. You've been given a blurb for example, the history. You can take some notes of what you're going to talk through and make sure that you're ticking off all of those bits, but you just have to leave them behind at the end. If things go wrong, move on. They might not have really gone wrong, and often people mess up the next station because they're still thinking about what they think they did wrong in that station. So you've got those 4 minutes to take a breath, drink some water, pace yourself. Don't make up signs. Harder to do now because it's the dependent cues system, but that is, not great. Sometimes examiners get it wrong, and if you think that has happened, raise it the same day. It's much harder to raise a problem after the day. So think, if you think that it's not been explained properly, someone was on their phone instead of watching you, talk about it then on the day. They shouldn't, but just, you know, things happen. And then forget about it. It takes an inordinately long time for you to get the results back. And so relax, enjoy yourself. If it all goes wrong and you don't pass, that is okay. The world will not collapse. Lots of people don't pass first time. I passed second time. There is a consultant at one of my old hospitals that passed seventh time, and I only know because they tell us all the time, and to reassure us, because you know it's okay. Revising for clinicals, as I said, I think it's the most useful of the exams, so it does make you better. Sometimes it is just luck, but sometimes you know what went wrong, or you can tell from the feedback, and just don't do it again. You get a copy of all of your mark schemes, and they should give you useful feedback and advice. There's it's much more detailed than it used to be, and so it will guide you in terms of your practice for the next one. So this is some of the useful things that I like. So the MRCPCH website, I'll stick the thing in the chat, that particular page, but generally there's lots of useful things on it. This is the London School of Paediatrics MRCPCH page. It's there's lots of videos on it that are from previous versions of the exam where there were children, but they are still useful, and that's where the development in a page document is. The London School of Paediatrics YouTube page has lots of lovely videos. It will have this recording on very soon, but it has lots of videos about different topics and things that are useful for all of the exams, but including this one. A silly amount of children put videos of their a silly amount of parents put videos of their children on YouTube, and so there are loads of examples of gaits or of rashes or of breathing things or of specific syndromes, and so you can really learn a lot looking at those alone. Think about guidelines and things, and patient leaflets are really nice in terms of thinking about lay language for how to explain things. Great Ormond Street has some good patient leaflets that I used during revision that are great for those sorts of niche things that you've just never really thought about how to explain in a non-technical way. MRCPCH guidelines, nice, and sign guidelines and BAFM guidelines for things like preterm counselling and things. There's some great stuff on there to use. There's some lovely podcasts with information about the exam specifically and different topics. In terms of books, this is the pink book that I talked about earlier, that if you do all of the stations in there, you will have covered anything that could possibly come up in terms of communication. It's not that long, it's sort of, you know, a book, but it's not a thick book, so it is doable. That is that. This is an older version of the, there's a newer version since, but it's really good in terms of talking through the different cases and different histories that can come up. These are old, and for they were old when I used them, but they're really old now, from very old, very far back versions of the exam, but they are good in terms of having you know, children haven't changed that much, so the information that is in them I thought was still useful. And as I said earlier, think about looking at the syllabus, because it is what they are using to design the tests. Fab. So I'm going to stop sharing if I can, and then I am going to get Kate Regan, who is a lovely trainee who has sat the exam recently, to talk to you for a bit.
Hello, can you hear me properly?
Yes.
I should just apologise in advance, firstly, that I've obviously just found out that I'm doing it, so feel free for people to ask me specific questions if there's anything that they want a specific answer on. I am also holding the neonatal registrar bleep, so there's a small chance that I'll get paged away, but hopefully I'll be fine. So I am an ST3 in South East, and I sat the exam in June. Am I mainly talking about what my experience of non-patient facing exam was like? Yeah, so no patients this round then. Okay, so I guess it's probably important to acknowledge that it is a bit weird in comparison to the OSCEs that people have experienced in the past, and certainly I haven't done an OSCE since medical school, and it was quite strange, but I think that the key is to practice that scenario as much as possible, because actually the thing that's really tricky is speaking within the time limit, because although the exams themselves are not that complicated and you'll all be doing them every day as part of your job, the level of detail you're expected to describe is quite high, and it can be quite difficult to fit all of that in 6 minutes and take in what you're being told in terms of cues. So I think, and I certainly, when I started practicing, was just really reluctant to talk because I felt ridiculous. But the more you practice, the more confident you become, and actually by the time you got to the exam, I think the group that I studied with all kind of felt like we had a system. I think it's good if you, I think different people had different things, but we had quite a set thing that we did at the beginning of every station, where we kind of described that we would introduce ourselves to the parents and the child, that we would explain why we were there and take consent, you know, wash your hands, put on appropriate PPE, and plot the child an age and sex appropriate growth chart right at the beginning, because then you don't forget to say it. And then you can say, you know, start looking around the room and describe the things you're looking for. So actually, I think that the short clinicals, once you'd had some practice, I think were actually okay, and I certainly found them okay in the exam. I think the thing to bear in mind is that the typical exam scenarios you're not restricted to that in this setting, because you're not relying on having a child with a stable clinical chronic problem with signs. And certainly that was the experience of the group that I sat the exam with, was that we did get an acute presentation of one of those stations, which I think is very different from what normally happens, and was also a bit off-putting in the exam, because actually you were given the observations and things outside and the child was shocked. And so then it was hard to know, actually, do you want me to carry on palpating the liver and the spleen, or do you want me to do what I would do in real life, which is an A to E assessment? So I think when that happened, the way that most people dealt with it was by just asking, I think, to say, you know, well, actually, do you want me to do an assessment? Actually, they didn't want you to do an A to E assessment, which was bizarre. But I think just be aware that acute presentations might come up in the short clinicals. In terms of the other stations, the communication stations felt much more normal OSCE territory, because we had actors, and that felt, yeah, it just felt much more like a normal OSCE. So I had an antenatal counselling scenario and a discussion with the nursery nurse about the management of a child, so it wasn't a parent, which was odd, but the kind of station itself I think was not that unexpected. So they felt quite normal, and I felt like the emphasis in those stations is all just about the quality of the communication, because actually the antenatal counselling, the topic was not one that I would have expected, and my learning point from that was, wow, clearly don't know much about clefts, but I got full marks in that station. So it's obviously about the way you deliver the communication, as long as you don't say anything completely mad. The video stations I found just utterly bizarre, to be perfectly honest. The video quality is not the best necessarily, and certainly one of the video stations, at first I was just completely off track with what they were looking for, but they did kind of guide you towards what they wanted you to diagnose. And once I realised what it was that they wanted, it all was fairly straightforward. And I think in general, most of the examiners I would say, without being kind of leading, were reasonably good at indicating whether you were on the right track or not. So I think the video stations are weird, but one of the things that I found most helpful actually was that we did some practice with one of the neurology registrars who went through some videos with us, and I did some practice with obviously it depends where you're based, but I was in a DGH at the time, and one of the consultants here who has access to VCreate for kind of clinical videos of like abnormal movements and things, we did some practice using that, and that was a really useful thing to do. So I would, if there's any way that you can get access to anything like that. So if there's like a consultant who's got a spin in neurology, if you're in a DGH, for example, I think that's really worth doing, just to practice talking about videos in front of someone who isn't a friend, because it's quite hard to find videos that don't, you know, give you the diagnosis and the title on YouTube, for example. And I did use the ones on past tests, but I wouldn't really say that they were particularly representative of what I saw in the exam. So it's a tricky one to find resources for, but if you can find someone to practice it with, and bear in mind that there is value when you're doing the videos and even kind of making statements like, you know, I can see that there's a child of approximately this age who looks well or unwell, and if they're doing things, make a comment about whether they're developmentally appropriate, because actually when I was practicing with one of the consultants, she was like, actually it just demonstrates that you're used to working with children and that you know what you're talking about, so it contributes to the overall impression. So I would recommend that. Let me think, what stations am I missing? The history and development. I guess I think probably like a lot of people, development was the station that I felt the least prepared for, because I hadn't done community paediatrics at that point, so it's the thing that I was least experienced in. But actually, you know, the developmental history is realistically very similar to the kind of history that you would take in any scenario, with just a more detailed focus on specific aspects of antenatal and birth history, and then obviously specific things about the development. I think it feels very artificial because you're not allowed to ask about the domain of development you're expected to examine, which of course you would never do in real life. But I think the way that I prepared for it was that, you know, I used the table from the website and kind of learnt that off by heart. And during the prep time, you've obviously been given the age of the child, what you're expected to ask questions about and what you're expected to examine. And I used that time to make a list of all the milestones that I would expect at their age and the developmental stage below that, so that I knew where to go and in what order. And actually overall the station went quite well, and there was no specific diagnosis, which again I think was something that threw me a little bit. But actually what they wanted was for you to take a detailed history, pick up on all the red flags in terms of the family history and development, of which there were quite a few, and present a reasonable suggestion of investigations. So your kind of basic developmental delay bloods, but also genetics, and this particular child probably had some sort of neuromuscular problem, so you know there was some kind of specific things about that. But actually I think I felt quite intimidated by that, but overall the station went fine, and the community paediatrician who delivered it was very supportive, and all the equipment that you would be expected to describe use of is in the room, so that acts as quite a good prompt, and you can obviously take your notes in with you, so it wasn't as bad as I expected. And the history station, again, I mean, it's one of the more realistic ones because you've got an actor to speak to and get the history from. 15 minutes, I think it is, for the actual talking felt like an eternity. Because I think in real life you're so used to asking things really quickly, and I had covered probably the most detailed history I can possibly imagine in about 10 minutes, and that was a bit weird because you're obviously not allowed to start early, but that was probably one of the more realistic scenarios, and less kind of less bizarre, I would say, than the short clinicals. I don't know if people, I don't know if it's valuable if people have got specific questions that they want to ask. I can't see the chat, but I'm happy for you to relay them, Katie, if that's helpful. Can I just quickly answer this page? I'll put you on mute.
Fab, thank you. So yes, any questions? From there was lots of useful things in that, but the people who become examiners are nice people who are enthusiastic about trainees, and they want you to pass, and so they will try and help you. Just, you know, follow their lead. Any questions? You can either chat aloud or write in the chat if you wish. Otherwise, thank you for coming, and I've put in the chat the link for the MRCPCH Guidance Hub, which has lots of useful stuff, the YouTube page where this will go, and so you can share with anyone who couldn't come. and the MRCPCH London School of Paediatrics page, which has some nice things. Question from Jennifer James. Did you find attending any particular outpatient clinics useful as revision? Until Kate returns, I will say that I did, particularly things where there's specific signs that you might not necessarily see regularly on the ward. So things like haematology clinic to feel some enlarged spleens and cardiology clinic to listen to some murmurs, the sort of more stable things that you won't necessarily see when you're sort of mostly in an acute place. And you can always assess the child's development whilst you're watching them. Kate.
Sorry, I'm back now. What was the question? Sorry.
A question about did you find attending outpatient clinics useful for revision?
So I guess what I would say is, was it that useful for the actual exam when you're describing the examination? No, it wasn't, because it's pattern recognition, but the exam isn't just about the exam, it's about the rest of your clinical life. So yes, I would definitely say that the job probably taught me more than any amount of revision did. So I think there's loads of stuff that they can give you pictures of in the exam that I would never have seen in real life. So things like, I guess because obviously I've only really worked in Edinburgh and we don't have, for example, inpatient renal, like I hadn't actually seen a mitral or things like that before I looked them up before the exam. So I think definitely worth going to clinics if you're in a position that your rota allows you to do that. I definitely would, and I do think it would help you indirectly in terms of, you know, expert input and stuff.
There's a question about the video station. Do we get the information after the video or within?
You get before.
So, yeah, so you get the sort of blurb and then the video, and then there's the questions from the examiner afterwards.
Oh, I see. Yeah. So you get, when you go in, you get 3 minutes to watch the video.
Yeah. And
you can watch the video as many times as you want.
Yeah.
And then after that 3 minutes, they knock on the door and then they ask you questions.
There's a question in the MSK station, if the abnormality is in the knees, do you have to do the whole PGALS exam, or can you focus on the lower limbs exam? Can you ask the examiner if it's not clear? Yes, you can always ask the examiner if it's not clear. I would say that it does depend on the situation. If they have said examine the knees, and say that you would like to do the other things. If they have said there is a gait problem, then it might be worth starting at the lower limbs. And if you're going completely wrong, the examiner will tell you. PGALS is useful in some settings, but not most. Would you agree, Kate?
I would agree that I would say that actually I really worried about that kind of ambiguous instructions, but actually the instructions are rarely ambiguous. It will be like examine the knees, and then at the end I would be like, you know, when you present at the end, I would just say to complete my examination I would, you know, complete the PGALS assessment and, you know, consider a neurological examination of the lower limbs or whatever's appropriate to the scenario.
Yeah. Question, can ENT and opthal come up? Yes, they can. They are less likely to, but they absolutely can. Another question for the history station, should we try and complete a full history, e.g. drug history, vaccines, birth history, even if they don't feel relevant to the scenario? Kate?
Yeah, absolutely. Like that is what they want you to do, is like every part of the history. So obviously, and 15 minutes is quite a long time actually. And so, you know, they expect you obviously to do all the kind of history of presenting complaint, but they are expecting past medical history, family history, social history, like the whole picture. I would say that you've definitely got time.
But also, if it's not relevant, then there won't be anything. So if you say, have you had all your vaccines? They'll say yes. If it is relevant, then they'll say, actually, no, I've not had these specific ones. And then you'll know that it's important. Yeah, exactly. And I think basically if you ask all the questions and the answer to everything is no, they're completely fine, then just don't present it back at the end. Yeah. I'm not sure if I've gotten through to the right number, but I'm trying to bring my no other questions at the moment. Anything else? Wonderful. Thank you, Kate. Typing. Give her a minute. Do we ask for heads in all teenagers? So I would say it is definitely useful for heads sort of going through home education, etc., drugs, sex, social, is really a really useful way of doing a quick screening for those sorts of things. And if it is a teenager, like a teenager with diabetes who is now not taking their medication, you need to go through all of those things. And same as for, you know, vaccinations or whatever, if there isn't anything, they'll just say no. If there is something, they will flag it. Kate, any thoughts?
Yeah, I would agree that I think if you were to get an adolescent in the history taking stage, and I think that they probably would expect you to do that. And I think if, you know, if it were to be a teenager in something else like the short clinical, I guess, again, you know, you'd be bearing it in mind as part of your differential or your discussion, and, you know, perhaps saying that you would, you know, discuss with the child, like see the child by themselves afterwards or whatever. But yeah, I didn't have any adolescents in my exam, but I think that I would have expected that they would want you to do that if you got one.
Yeah. Are we expected to say discuss with senior consultant in most stations? Kate?
That's a good question. I'm just trying to think about what was wrong with all the children that I got and what I was expected to do. So I think that probably, yes, that was relevant, but I think it has to be done in a specific way. You can't just be like, oh yeah, I'd escalate this to my senior registrar. Yeah. They're like, who do you want to see this person? And like in the cardiology station, you were like, well, I'd want to discuss it with the cardiologist, and I think they need these investigations. And they said, what time frame do they need to see the cardiologist in? So you have to be able to say, you know, oh, routine outpatient, urgent outpatient, or today, basically. So I think, yes, the general expectation is that some other person will need to be involved, but don't just kind of arbitrarily go, I'll discuss it with my senior.
Yes, you're the expected level of you at this point is as a brand new registrar, so you are not supposed to be able to cope with everything, but you are supposed to come up with a plan and take that to your senior, as you do. Fab. Last call for any questions. Smashing. Okay. In which case I will stop recording. Thank you very much. Ooh.